Now, that's a language, of course, that's the language, a trauma-informed model of working with women in pregnancy and the perinatal period that is not necessarily the language of mainstream medical services. So again, how do we set up our services where we better integrate a trauma-focused approach, a child protection approach, because we also have to think about supporting these parents, some of whom may have difficulties in parenting. How do we integrate those approaches with standard medical services, or make systems of care more responsive to the needs of people who've experienced trauma? Now, I think we're just at the beginning of trying to talk about that, but certainly infant mental health services, which is where I work, see these issues every day. We also see the way that as a system the hospital medical complex doesn't necessarily respond to them very well, and how they certainly need to better inform mental health systems and how we think about mental health care and treatment. So the parents that we loosely describe as having risk factors or high risk might be at that end of the spectrum where it's going to be very difficult for children to develop secure attachment relationships. And that's sometimes because parents are anxious, parents are inconsistent. Sometimes it's clearer that some of the parents we see are having conflicting and confusing emotional responses to their own children. On the one hand, desperately wanting to get it right, maybe wanting to have very positive experiences with their child. On the other hand, sometimes having rather unrealistic expectations about what their child can do for them. So fundamentally, having a wish, which I think is perfectly understandable, that this relationship with the child is going to be easy, perfect, and meet all the emotional needs. And that particularly applies to parents who we might see who have difficulties with current relationships, or who've been exploited in current relationships, who are emotionally needy. So having the child becomes a major focus for them in terms of emotional recovery. Now that's, I think, a very positive motivation, but we also have to think in this complex situation about the child. A child can be very burdened by trying to provide everything that a parent who's needy might want from them. Children will certainly try and live up to that, to be the thing that their parent might want them to be. But of course we're also mindful of children's needs for care and support, and having a parent, an attachment figure who can actually recognise their needs for emotional support and care. So some of the children we see in these high-risk relationships end up with what we would call disorganisation of attachment, which is really a state of being highly anxious, really not having a coherent way of managing anxiety about the carer and their emotional availability. So of course sometimes these children have experiences that their carer is very appropriate and very available, but at other times their parent might be in a puzzling and confusing way for the child, unavailable, poorly responsive, or internally preoccupied. And that again needs to be thought of as one of the legacies, potential legacies of early trauma. That for many of our parents with those histories, having a child fundamentally reawakens or rekindles those early experiences. So memories which might have not been very conscious or might have been more effectively put to one side are suddenly there in the context of having a relationship with a child. It's impossible to forget. And essentially what people describe frequently in those situations as thinking again about their own experiences, often of being frightened, of being abandoned, of being poorly responded to. And it's not an accident, of course, that that happens when they have a child themselves. So it's very much that model of post-traumatic response, and we see the way that gets reenacted in the relationship with the child. Now, some parents are very well aware of that. I had a woman last week who said to me, when I look at my baby, all I can think about is myself and what happened to me and how I was left and how I had these feelings, I had no idea what to do with them, and then I see my child and I'm scared that that will happen to her. Now, these are very powerful, but often people are very articulate about that. So we have crucial windows of opportunity about responding to that. And the response to that is not to say, oh, you'll be all right, sort of reassuring, paternalistic approach. I think from my perspective, and this is some of the parenting work that we're doing at Monash at the moment, is very much to say, yes, parenting after abuse is tough. It is. There are issues that are going to be there for you that you will know very clearly, and these are the things that it's very good to get some support with. And our responsibility, of course, then is to think about, well, what's actually going to work in that situation? Is it just sending people to generic parenting programs? Now, I'll get my little personal view about that in, but there are on the market at the moment about 170 parenting programs. Most are generic, some are good, and very few of them are aimed at high-risk situations or for parents who've experienced trauma. And yet the parents I see, many of whom go through a court system, might well be argued to go to, let's say, pp 3 or 4 times. They do repeat performances. And one woman explained to me a few weeks ago that she'd gone to one of those courses and the group were asked, what things would you like to talk about in terms of parenting? What's important for you? What are the issues that you think you should be able to get some help with? And this young woman, who was very courageous and had had a really very devastating history of sexual and other forms of abuse from about the age of 2 or 3 to when she was an adolescent. She said, this had happened to me, I've been abused in this way, I want to be a parent, I've got my new child, that's what I want to talk about, the way in which my abuse is impacting on my capacity to think about being a parent. Shock and horror throughout the group of less abused parents, and the facilitator, who was probably in a deep state of shock and needed therapy after that, said, oh no, this is a parenting group, we don't do that. So that to me, that said it all to me. That's the dilemma. In our unit, we've taken, I guess, the opposite approach. We start and designed approaches for working with the parents who we see every day. Parents who've been abused and maltreated, parents who are at risk in terms of their current relationships, highly motivated to get it right, struggling with that as a concept, monitored by child protection, some of whom have got heroin and opiate dependency. Okay, I mean, this is a common enough group of people that we need to think about. They're overrepresented in all our services, not just mental health services, but family support, child protection, whoever we name. Considered too hard, often treated in a poor way, put into the too hard basket, judged very early and very harshly, with benchmarks of behaviour and performance that none of us and the rest in the so-called general community would usually be able to live up to either. So I think this is a real social justice issue. This is very much a political issue and reflects something about our society's incapacity to deal with the reality of trauma in the lives of children and its effects. So we started with that group of people, and we start in our way of working, talking with them right from the beginning about, yes, it's going to be hard. Your views, your experience is absolutely correct. That most services and people that you're interacting with in a professional capacity have not responded to you in an appropriate way. You've not been heard. And I think that's the only respectful way of working with these sorts of experiences. Start from that perspective. And yes, then we do go on to talk about the fundamental issues that can arise as a result of early trauma that make parenting difficult. And that's the clinical role that we play, but we talk about that in a way that's engaging, that gives those parents, hopefully, some sense that this maybe is a relationship that they can get right, that they do have some, build up people's sense of self-efficacy and power in that situation, and actually empower them to become protective parents, even if that's anxiety-provoking. Now, I'm not being overly romantic about it, I hope. I also see some parents, sadly, who are not going to be safe parents, and we do need appropriate systems to deal with that in an empathic way, to hopefully prevent those sorts of things and to help their children who might be by necessity in alternate care. That's a whole other question that we're not really talking about today, but the way in which alternate care systems have also abused and traumatised children, some of the most vulnerable children in our society. So we have a whole series of related issues here. But these so-called high-risk parents are fundamentally people I believe we need to be much more respectful of and engage in a much more listening way to the reality of the experiences that they have had and how that impacts currently. We obviously need to understand attachment histories, and also we need to get a handle from a clinical point of view of where that person is at the moment when we see them. Are they at that stage of being able to start the hard and often very difficult process of thinking about their own trauma? Putting the story together, developing a narrative that is a containing narrative that allows these experiences to be thought about, to be communicated to others in an appropriate way, if that's what someone needs and wants to do, but fundamentally with psychological processes of narrative that give meaning to some of these events, which for a child are often incomprehensible, fundamentally confusing and unthinkable. So that's the long-term work, if you like, that many people in this audience are obviously familiar with, the concepts that rebuilding personal narrative and sense of self-coherence and self-efficacy in the face of having early abuse is a very profound and long-term process for some people. So we do need access to the range of therapeutic interventions that acknowledge that not all things are cured in 5 or 6 sessions of a cognitive behaviour therapy. Now, for those of you who might read the Sunday papers, I don't know if it got here, but in the Sunday Age 2 weeks ago, there was quite a nice piece about psychologists returning to psychoanalysis, and I read this with great interest, and there were some good comments by some of the analysts saying 6 sessions is not going to help people necessarily to recover from huge amounts of significant early trauma, that can be a lifelong process. That can be, it's not to say that everyone needs to be on the couch 5 days a week, but that there is a need for an understanding that some things take longer and that healthy therapeutic relationships can be important. And of course, there was some commentary asked for by a couple of very leading psychiatrists around the trap, including the former Australian of the Year. And I'll be cheeky because I can get away with it, but who said that they didn't think that was of any relevance at all, that there was not much evidence for the role of long-term therapy. So that was, and a certain other very prominent psychiatrist from Sydney, Professor Hickey, said much the same thing. This is deeply troubling. When, again, what that argument served to do was trivialise something that's an important discussion. Yes, of course, no one's advocating that everyone in society needs 5 days a week psychoanalysis. No, that's not the issue. The issue is about, are there people who need longer term interventions and support? Yes. Are there other approaches than cognitive behavioural approaches that are sometimes needed? And one of those being a trauma-informed approach. Of course there are. And so we had this very trivialising, dismissive responses from people who frankly should know better about the needs of many people in our community. So I found that deeply troubling. Was pleased to see the week after there were some letters in response to that saying, look, sorry, there's clear evidence not only about need but about approach. And that psychoanalytically informed approach, which, if we think about Freud when he got it right initially, was very much about trauma and sexual abuse of children and its relationship to mental health problems, can be very helpful. So maybe there is a need for us all to go around saying early Freud got it right. We need to think about that. And question why even leading commentators in our society can't acknowledge the reality of abuse and trauma of children. Because I think this is one of the fundamental issues. We are all in denial if we go around making statements like that, and we're not doing anyone a service, let alone the children.